Thanks very much for the invite to come and talk to you this morning. What I want to really inform you about is the commission that's been sponsored by the Royal College of Surgeons and kind of where we've got to with this. Unfortunately, the commission is due to report next month, and so obviously I'm not going to reveal some of the thoughts, certainly the top line thoughts that we've had, but hopefully I can kind of put into place where the commission is. The last time that there was any sort of forward-thinking publication about the future of surgery was Professor Al-Darzi's paper in 2008, Saws and Scalpels to Lasers and Robots, and looking at advances in surgery. And he said at that time that we need to localize surgical care where possible, but centralize care where necessary. And he used as examples of this operations that he thought could be done locally, such as these, and then operations that may need to be done in a much more centralized manner. Now, since 2008, as you know, there's been quite a debate about centralization of surgical services, and there has been even legal challenge to some centralization proposals. And indeed, the College of Surgeons at the moment is having another review on the organization of surgical service delivery. What he also said was using an example of advances, that of robotic surgery for prostate cancer, suggesting that the equipment was expensive, a lot of specialist training is required, and it would not make sense for this to be in every hospital to offer such treatment. The implication being that that robotic surgery perhaps conveyed advantage to those who had it. My thought actually is maybe not in every hospital, but it certainly should be available to every patient if that represents the highest standards of care. And I think that's what we should be aiming for in terms of our surgical delivery. Now, since 2008, there has been an explosion, really, of information and detail about surgical intervention. There's been several journals have come into being, and we've just heard about the British Journal, the British Medical Journal Initiative on Surgery, Innovation and Healthcare this morning, which I absolutely welcome. I think that's great. There's been various conferences about innovation, both in the US, in Europe, and of course the conference that we're having today. And there is a worldwide meeting on surgical innovation later next month. Now, in the face of that, there has been quite a lot of change happening in terms of our population demographics and our disease burden. If you look at these two images of the UK, you can see the darker blue represents the population aged 65 and over in 1996, and the predicted distribution of population in 2036. What's interesting about the slide on the left there, at least, is that the distribution of patients over 65 tends to be around the rural areas and the seaside, not in the big urban conurbations. Now, they might change a little bit here, but actually the big cities are still not overly populated with patients in their 60s and over. If you look at the life expectancy, that too is increasing, and with that, the burden of disease is increasing as well, particularly here with Alzheimer's disease, but also, as you know, with obesity and diabetes. The waiting times for treatment in England, I'm afraid, are matched by waiting times in the other home countries as well, and the waiting times are now just progressively rising. So the demand for the service that we offer is huge, and with that, the attendances and subsequently admissions from A&E are also rising, although interestingly, some data that was released from the college yesterday suggests that actually if you look at the number of admissions per working day in the first 6 months of each year, the number of admissions is actually dropping over that period of time. So demand is rising, age is rising, disease comorbidity is rising, and our admissions have actually fallen if you look at that. You'll recognize this gentleman. He's announced this week that the world's biggest opportunity for saving lives is going to be through technology. There are others who would slightly disagree with him in terms of whether or not that's really achievable. In the face of this, and obviously before the current Home Secretary was there, we had considered that the college, given 10 years has lapsed since the last review, and given the enormous number of changes that were happening, that this was an appropriate time for us to begin to look again about what the future of surgery actually held. Obviously, there are reasons for the college wanting to do that, given that it wants to be in a position to look at standards and standard setting, but also make sure that the training platform for future surgeons and surgical care teams was appropriate. So we established the commission in 2017, obviously to look at it over a reasonably lengthy period of time, over 20 years, and what the implications were for in terms of the NHS, the workforce, and clinical outcomes. Now, there's been a lot written about the future of surgery and innovation, and most of it looks at a specific entity like AI or robotics or genomics. And the idea of the commission was to try to draw some of those strands together, particularly when it comes to teaching and training. We started by conducting a fairly significant literature review and then asked for written evidence, and there were over 70 written contributions, including, thankfully, to Peter from the Ideal Collaboration as well, and we're very grateful for that. We had 4 days of oral evidence sessions, and they were all streamed live on YouTube, which you can watch if you happen to be bored. But it's quite interesting. And then we aim to publish next month. And obviously some of the work will be pursued through the College of Surgeons. The commission members are fairly diverse. There's some surgeons there, but certainly not all. There's patient representatives, there's representatives from the charity sector, there's junior staff representatives. There are also mechanical engineers, robotic engineers, Will Cavendish, who was involved with DeepMind, and Raj Chopra there as well, the well-known oncologist. So it's a fairly diverse group of people, and we've spoken to a vast number of different companies, colleges, interested parties. These are just a few of them, including the Ideal Collaboration up there. What's come out of this is that the changes that are in place are going to involve, obviously, minimally invasive surgery, particularly robot-assisted surgery, but also the changes in nanotechnology. There's going to be huge changes using imaging, and that will reflect on augmented reality and virtual reality and the way we use those, but also 3D printing and planning, and we'll talk through some of these shortly. Changes in transplantation, and that leads into the whole fields of regenerative medicine and stem cells. And then on this side, there's the data and digital technology revolution upon which all of this is based. And without that, we're not going to be able to move forward in the way that we would wish to. It's going to lead to hopefully much more personalized medicine, as indeed will the whole explosion of genetics and genomics. The aim is the commission is to put the patient at the heart of this, and really to look at the patient's journey from healthy patient and prevention through disease prediction, early detection, diagnosis, treatment, follow-up, and then management of long-term conditions and hopefully prevention of recurrence. And the aim will be to look at each of these different areas when it comes to the cycle of the patient's life. So if we just take a brief snapshot at some of these, and I said I'm not going to go into great detail because it's really the remit of the commission when it's published next month. But if we look at this, for example, simulation imaging and augmented reality, undoubtedly there will be an increased use of simulation to complement particularly existing training, but also surgical preparation, planning, and treatment. I think the simulation use will allow us to develop team training in a way that it hasn't previously been done, and it introduces the concept of collective competencies within a team. And I think what's important that is a team is able to deliver all of the required competencies necessary to complete an element of treatment. It brings in the question, of course, is who's going to be doing those various aspects of treatment within that team. Will it always be the surgeon, or will it be someone else? Hopefully this will allow better platforms for introduction of new technology, particularly in terms of training in that technology, if we can use simulation. From an imaging point of view, we're already beginning to move from anatomical mapping to functional mapping, and I'll show you what I mean by that in neurosurgery. The use of AI, particularly in radiology, in terms of diagnostics and pathology and ophthalmology, you've all heard about, and there's undoubtedly going to be more engagement with that, potentially increasing our diagnostic rate and hopefully allowing more clinician time as a consequence. And then using the augmented reality platform, there should be availability instantly of data and even support through that augmented reality program. The impact: better outcomes in early diagnosis, better introduction and uptake of technology, and the improved development of a surgical team, and even the development of virtual teams, such that they're not all in the same place. Some of the functional imaging we're now using in neurosurgery, and this is, I won't say it's commonplace, but it's recognized in the neurosurgical world. Here's a patient who sadly suffers a tumor in their dominant hemisphere, back part of the frontal lobe. What we need to know is the functional areas related to that. And as neurosurgeons, we've always relied on our sort of three-dimensional map. Now, using diffusion tensor imaging and functional MRI, we can actually plot out where the corticospinal tract is, where the arc versicolus is. So we know the relationship of the tumor to these vital, crucial areas. That allows us, using a navigation scan, to co-register the two things, so you can actually then go on and remove the tumor, hopefully in a way that's much more safe than it ever was before, and to a much greater extent. I would never venture this far back without having this sort of imaging, for my fear of leaving the patient hemiplegic. If you look at robotics, and excuse me for the slide, there's too much on here. Robotics is seen as something that's going to replace surgeons. I don't believe that is the case at all. The robotic surgery is actually robot-assisted surgery. It's a tool and will continue to be a tool. And I don't believe we're ever going to get to the point where a robot takes over the place of a surgeon. That relationship between a surgeon and a patient, so in other words, that human relationship, I think is always going to be crucial. However, in the next 5 years, undoubtedly, the prices of robots are going to come down. There's already several systems coming online later this year, which are much smaller, much more versatile, much more maneuverable, and hopefully, therefore, at a more affordable price. It may be that we can begin to use a small number of automated tasks within the next 5 years. There should be specific smart tools, and there will be better platforms for data collection about those procedures. In 10 years, again, I think we're going to see more, smaller, faster, more adept robots coming in, and some level of machine learning. But there's also going to be better ergonomics as a consequence of this, which may mean that there's a longer lifespan for the surgeons who are actually using these tools. In 20 years, I would think that we would see national specialist centers for highly complex procedures done using robots. The robots themselves may be able to do more specific tasks as a consequence of that. So better use of robot-assisted surgery is undoubtedly a way forward. If we look at big data and genomics, I think this is crucial and, again, pivotal. In the short term, I think there's going to be utilization of data to predict population health and disease, and also give us more information about surgical outcomes. But in the longer term, what this will allow us is to move much more towards personalized care for the individual. Better knowledge about the relationship between their genetic profile, their disease profile, and therefore the outcomes. And there is some suggestion that actually the genetic profile can now even predict or be used to help predict not only outcome from surgery, but actually the development of complications from surgery. Using cell-free, this is using liquid DNA, may become part of our armamentarium in terms of picking up disease earlier. So earlier intervention and moving towards preventative surgery in a much more precise way. But it raises concerns about data, access to data, consent, which again I'm going to allude to a little more in a moment. there is a feeling that all of this is going to be applicable to the unusual, the rare, the difficult. And I think if we're going to utilize this technology to the full, we've got to understand what the common procedures are that we do in this country, what the common procedures that are done, and how we can apply this technology to these. And this is a list of the common procedures that we do. The commonest procedure, and this is excluding skin lesions and tooth extraction, the commonest is cataract surgery here, 400,000 a year, 2 million over 5 years. Then after that, we look at long bone fractures, femoral fractures, caesarean section, arthroscopies, cholecystectomy, and then moving down to the bottom with spinal surgery. Now, I think it's very important we don't lose track of these if we're using this technology, which may develop in the more complex environments. I think we should make sure we try to apply it to both. Now, the unintended consequences of this are the worried well, and I'm actually going to talk about this on the radio this morning. This potentially is a nightmare for the worried well. In other words, there's a vast amount of information going to be available, and increasingly so. So not only is there going to be information available about disease and disease processes from the internet, there's going to be the access to genomic profiling, which may be even purchasable by individuals in the not too distant future. There's going to be lots of devices that we carry with us, all of your smartphones collecting data about you all of the time. And all of that is going to become more sophisticated and more accessible. And the end result, particularly in a population where there's increasing burden of chronic disease, is the worried well. And I think we just need to take a note about how we manage that. Equally, we need to make sure that these developments are accessible for all. We know from the GIRF data that already there's a lot of health inequality, and we need to try to be sure that these advances are applicable to all and accessible to all and not limited to those in specific areas. The challenges for the Commission are obviously looking at workforce, looking at changes of the curriculum, and I would particularly look at changes in the way we as surgeons are going to work in the future. And I think we will have a more diverse career. We may be surgeon teachers, surgeon managers, surgeon innovators, surgeon scientists, a phrase termed by Professor Kerr, and even what I am now, which is a surgeon mentor, and I spend time supporting the staff in my unit. I think our relationship with industry partners are going to be so important in terms of developments, but also training, and then, of course, the vital relationship with patients and their families. Perhaps top, though, is the need for the introduction, adoption, and regulation of innovation. And clearly that's the subject of your discussions over yesterday and today. And indeed, data and collection of data is absolutely crucial if this is to be successful. If we look at innovation, this is seen as a solution to our future healthcare problems, but there are issues about evidence-based mechanisms, about lack of unified adoption strategy, and as you know, there's very complex frameworks for clinical trials. The NICE Interventional Procedures Programme will actually publish on about 30 interventions per year, and that's all, and there are reasons for that, and yet they're requested to look at far more. You're going to hear from Sir Michael Rawlins later on today about the role of the MHRA. So in terms of looking at new ways, the ideal collaboration, but there are one or two others that I've just mentioned there. My time's up, so I need to finish. So I think the future of surgery is bright. I think there's lots of interesting innovation on the way. I certainly think that the future is going to be evidence-based, and I'll leave it to you to debate how we collect that evidence. I think it's going to be personalized, and we've heard in the news recently about the enormous success in terms of treating prostatic cancer by immune-based therapy on personalized treatment. It's going to be moving much more towards preventative instead of playing catch-up, which is what we are doing, and we're clearly going to be making it more minimally invasive. I think the delivery of surgical treatment is going to be based on a team, and team-based approach I think is all important, and it's going to be using digital technology to collect the data that's going to allow us to drive those. And finally, it's going to be based on informed patient preferences. The patient is the pivot, the crucial part of this, and what we have to get is that informed consent correct. Thank you very much indeed.